His vital signs had been well controlled, but now he was becoming increasingly hypertensive and tachycardic, which is bad post-aorta repair. He was anxious and shaky and nauseated. He became diaphoretic. I kept asking, "Are you in pain?" thinking maybe that was the source of his symptoms, but he denied it. He was still alert, but a little agitated and not fully making sense. Still interactive and following commands, but he kept forgetting where he was and why he was there, could not get comfortable in the bed. The more I watched his mannerisms, the more he felt like patients I had encountered before who are withdrawing from something. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Hey guys, and welcome back to the Rapid Response RN podcast. This week, we're talking about a patient population that almost every nursing specialty, well, maybe not pediatrics, but every other nursing specialty gets to care for, and that is ETOH withdrawal. Caring for intoxicated patients is challenging enough, but I would propose that caring for patients in withdrawal can be just as much, if not more challenging. There's a lot of new evidence and nerdy patho that I'm looking forward to discussing this episode, so let's dive into a case. I was working in the CVICU, and my patient was 3 days post-emergent aortic aneurysm repair. He didn't plan on being in the hospital. He presented to the ER with chest pain, and they found a big old type 1 dissection. So he went straight to the operating room. Everything was going great and right on course until the day that I took care of him. We had successfully extubated that morning. He'd been off sedation since early in my shift. His vital signs had been well controlled, but now he was becoming increasingly hypertensive and tachycardic, which is bad post-aorta repair. He was anxious and shaky and nauseated. He became diaphoretic. I kept asking, "Are you in pain?" thinking maybe that was the source of his symptoms, but he denied it. He was still alert, but a little agitated and not fully making sense. He was still interactive and following commands, but he kept forgetting where he was and why he was there, could not get comfortable in the bed. The more I watched his mannerisms, the more he felt like patients I had encountered before who are withdrawing from something. Sure enough, I pulled his initial H&P and noted that he had stated that he was, and I quote, "an occasional drinker." He said this on his admission assessment, but all signs were pointing to the fact that this occasional drinking was probably more like an everyday drinking situation. He had all of the classic ETOH withdrawal symptoms: anxiety, irritability, tremors, nausea, diaphoresis, tachycardia, hypertension, and some confusion. So I called the cardiac surgery PA and received orders for some IV push benzodiazepines and a CWA protocol. With that, I was able to manage the symptoms, and I got him safely through the danger zone of his withdrawal period, and he never had any seizures or any other life-threatening complications of the alcohol withdrawal. He was downgraded off of our unit the next day, and as far as I know, made it safely to discharge. Now, before you go judging the cardiac surgery team for not starting him on a CWA protocol prophylactically, let me just say that I actually see this a lot. Either the patient comes in emergently and we never really get a chance to ask about their alcohol intake, or it was asked, but the patient didn't really tell the whole truth about how much they drink. I remember when I was working in the ER and I asked the patient once how often he drank, and his answer was, "just socially." To which my reply was, "Well, how social are you? Once a month? Once a week? Are you socializing all day? He laughed and then admitted that he drinks a 6-pack of beer every day after work, and sometimes more if it's been a really bad day. And on the weekends, he drinks from the time he gets up till the time he goes to bed. I told him that I appreciated him sharing that with me because it would help us provide him the safest care for when he starts withdrawing from the alcohol that his body is so used to having daily. So yeah, a true social drinker who only drinks on the weekends or holidays might have no symptoms of withdrawal for their whole hospital admission. But someone who'd been drinking consistently for years is going to have some withdrawal symptoms creeping up around day 2 to 4 of their hospital admission, and sometimes even sooner, depending on the severity of their alcoholism. So, why does alcohol withdrawal cause these symptoms? Well, let's go back to the patho here and buckle up. This is some heavy, nerdy brain chemistry pathophysiology. So if you've got me playing on double speed, you may want to slow it down a bit for the next few minutes. So alcohol has potentiating effects on the inhibitory GABA neurotransmission system. GABA is a neurotransmitter that inhibits excitation of neurons, which ultimately leads to calmness and relaxation. And alcohol potentiates this whole system, which is why people like it. It can help you feel calm and relaxed. Alcohol also inhibits the excitatory glutamate neurotransmission system. So in short, glutamate is how your brain can process information, learn, develop memories. It also helps you have motor functioning. It does this through the action of the NMDA, or N-methyl D-aspartate receptors, NMDA. Remember that because it'll make more sense in a second. So when you add alcohol to your system, it inhibits glutamate, making it more difficult to process the auditory and visual stimulation. Your motor system's impaired, and often there is limited or no memories of events that occurred while intoxicated. So, in short, alcohol potentiates the GABA with its calm and relaxing effects on the body, but it inhibits the glutamate, which makes it difficult to process, remember, and impairs one's coordination and speech. So, in chronic alcohol use, the body has had to adjust things a little bit to preserve homeostasis. There are 2 adaptations that occur. One, it increases the number of NMDA receptors in an attempt to maintain normal excitatory function, aka to keep you awake. And the second thing it does is it increases glutamate release so you can still walk and talk and function. Ever cared for a patient and you go to their alcohol level and you wonder, how in the world are they still speaking so clearly and walking so normally with their blood alcohol level being that high? Well, their bodies have adapted to chronically having alcohol on board, and they are not as impaired by its effects because of these adaptations. Another way to look at it is the body must dump more NMDA and glutamate to balance out the alcohol, or the person could not function. But when the alcohol that has been keeping things balanced is removed, well, now there is so much excitation in the brain and not enough calming GABA to go around. So what you get is an anxious, shaky, irritable, confused, tachycardic, hypertensive bear that might seize if you don't help regulate the GABA and glutamate system. So before I talk about how we can help, we just back it up a little bit and talk about the initial presentation and management of someone who has chronic alcohol use. So first off, no one wants to be an alcoholic. No kid says, when I grow up, I want to become addicted to alcohol to the point that if I don't have it, my body cannot function properly, and I want to spend large portions of my income on alcohol despite the long-term negative effects it has on my physical and mental health. No one says that. Alcoholism, or alcohol use disorder, is a complex condition influenced by a combination of biological, psychological, environmental, and social factors. People develop alcoholism for so many different reasons, but several underlying mechanisms contribute to the progression from casual alcohol use to dependency. Now, you don't know what your patient's childhood was like, what type of trauma they've experienced, or what mental health challenges they're facing. Alcohol use is a vicious cycle. The sadder you feel, the more you want to drink. The more you drink, the more difficult it is to cope, and you drink even more. I can't tell you how many patients have confided in me that their alcoholism started after something tragic occurred in their life. While caring for both intoxicated patients and those experiencing alcohol withdrawal can be challenging, we have the unique opportunity to offer compassionate, non-judgmental care during a time when they are particularly vulnerable. Rarely does judgment inspire someone to change their life. Instead, it is often compassion that helps a person with alcohol use disorder recognize their worth and believe that they deserve love and a better future. So if you think using a sharp tone or making rude comments will teach them a lesson, it simply doesn't work that way. Secondly, let's talk about what to expect and when from patients who have alcohol use disorder who are withdrawing from alcohol under your care. Hey guys, I'll get back to the episode in just a second, but I wanted to pause to let you know that if you love my podcast but wish there were more of these awesome episodes, well, I have great news for you. There is more. My Rapid Response Academy is basically podcast 2.0, plus the huge added bonus of community. I love hosting this podcast, but it's just me, recording into a microphone often by myself. And this extroverted gal who loves to both teach and mentor nurses just wanted more. So in the community I created, I get to teach live every Friday and break down topics that I think every nurse needs to know. From deep dives into the pathophys of every emergency you can think of, to some of the heart of nursing topics as well, like how to advocate with confidence for your patient, how to de-escalate situations, how to deal with bullies on the unit, how to be an amazing preceptor and charge nurse, and some of the mindsets and boundaries that have helped me stay in nursing for the last 20 years, not burn out, and thrive at the bedside. I love the opportunity to answer your questions live, and it's such a joy to see nurses supporting each other in this community. So, if you're an acute care nurse that wants to expedite your growth as a nurse and invest in yourself so that you can provide the best care to your patients, you would love my Rapid Response Academy. So to learn more, I put a link in the show notes for you. Hope to see you there. So when and how severe symptoms are depends on so many factors, from how much alcohol they consume to their liver function and other comorbidities. Not every patient follows this timeline, but here's the typical progression. At about 6 to 12 hours since the last drink, the early symptoms start to occur. Some tremors, a little anxiety, a little nausea, maybe some sweating. Might feel a little insomnia, they can't sleep. At the 12 to 24 hour mark, symptoms start to intensify. So now there's some confusion, agitation, maybe hallucinations, increased heart rate, increased blood pressure. At about 24 to 48 hours, that's when seizures could occur, along with worsening tremors, worsening agitation, and worsening hallucinations. Between 48 to 72 hours, so that's when patients are at highest risk for what's called delirium tremens, which is the most severe expression of alcohol withdrawal. Those patients have extreme confusion, agitation, hallucinations, high blood pressure, fever, seizures. They often need such high doses of benzodiazepines and barbiturates to get their vital signs and behavior under control or to stop their seizures that they have to be intubated and placed on propofol. These patients are sick. But not every person who withdraws from alcohol will develop delirium tremens. It can be life-threatening if untreated, but again, not every patient gets to that point. Usually somewhere around day 3 to 7, symptoms start to gradually subside. So the patient may still have some anxiety, irritability, insomnia. That could linger for weeks, actually, but you'll see the symptoms start to get better. So back to the case study that I opened with, I met my patient somewhere around hour 60 to 72 with no alcohol. His withdrawal symptoms had been blunted by the sedation he was under while intubated. But once that wore off, his withdrawal symptoms started to really ramp up. So if your patient is a daily drinker, it would be prudent to get ahead of the withdrawal symptoms and not wait until the symptoms are severe to treat the withdrawal. That is safer for the patient and for the nurses. But how do we treat the symptoms of alcohol withdrawal? Well, we have some options. We need something that can bind to the GABA receptors, decrease neural excitability, and lead to that calming effect on the brain. And it would also be nice to prevent seizures. Conveniently, both phenobarbital and benzodiazepines can do that. Phenobarbital, however, takes it a little further and inhibits glutamate, an excitatory neurotransmitter, which adds to its calming and anticonvulsant effects by reducing the hyperexcitability of neurons during withdrawal. Up until about the 1980s, barbiturates were the first-line agent for alcohol withdrawal. But then benzodiazepines came out, and they were marketed as the safe, benign, newer, and better option. Medicine as a whole made a switch to benzos, but in recent years, we're learning about the many harmful effects of benzodiazepines. In fact, the very delirium that we're trying to treat can also be exacerbated by benzodiazepines. And fortunately, I have seen a huge shift in my career from thinking that everyone needs a benzo to help them deal with the stresses of hospitalization, be intubated for the slightest bit of agitation, to now we're trying to avoid benzos at all costs, or at least limit their use as much as possible. There's obvious times we must give benzos. We don't use them sparingly in those that have status epilepticus. But for my elderly patient who has developed a little delirium, I no longer reach for the benzos to help him calm down and be compliant with his care. There are much better and safer options. We do, however, still use benzos for the treatment of alcohol withdrawal. The ones that I most commonly see are lorazepam, also called Ativan, and diazepam or Valium. Many facilities utilize a CEWA scoring system to help manage patients who are withdrawing. CEWA is the Clinical Institute Withdrawal Assessment for Alcohol. It's a standardized tool that's used to assess the severity of alcohol withdrawal symptoms and guide treatment decisions. It consists of 10 categories, including nausea, vomiting, tremors, sweating, anxiety, agitation, tactile disturbances, auditory and visual disturbances, headaches, and orientation. Each symptom is rated on a scale with a maximum total score of 67. A higher score indicates more severe withdrawal, and scores help determine whether medical interventions, like medications, are needed. Typically, a score below 10 indicates mild withdrawal, while scores over 20 indicate severe withdrawal, requiring more intensive treatment. At my hospital, doctors can order the CEWA and then choose which score will correlate with the dose of benzodiazepine they want. So the nurses use it like a sliding scale. If the CEWA is this number, they give this many milligrams of a benzo. It's great, but not perfect because it's a very subjective assessment and often tends to result in patients being oversedated. So that brings me to phenobarbital. I am just starting to see this emerge as an option for treating patients with alcohol withdrawal, but I have found it to be very effective. A lot of the hospitalists that I work with will give the patient a loading dose in the ER upon admission, kind of prophylactically before withdrawal symptoms even kick in. It's not as sedating as benzos, and it's not deliriogenic. And the half-life is crazy long, like 3 to 4 days. So as we continue to give smaller doses in the coming days, the amount on board inside the patient starts to build upon itself, which is perfect because that's as the symptoms are starting to ramp up and be their worst. Additionally, it will still be in their system to help them through the tail end of their withdrawal, even after they're no longer in our care at the hospital. I love phenobarb. I have seen patients do very well and not require as many benzos or other forms of sedation, especially for patients who have a history of having, say, seizures with alcohol withdrawal. Let's get that phenobarb on board as soon as possible. However, even though I would personally prefer phenobarb, and the literature is now leaning in favor of it too, it's not for everyone. It's contraindicated in pregnancy, and if your patient has advanced cirrhosis with hepatic encephalopathy, sometimes phenobarb might just send them over the edge of over sedation, and they may end up requiring intubation to maintain appropriate oxygenation and ventilation. So I would use extreme caution combining phenobarb with a patient who's already sedated from their disease process. And speaking of disease process, if you want to learn more about liver failure and all of the pathophys there and how to treat it, I did a whole series on it. It's episodes 108 through 111. One more tidbit I wanted to add here is that it's easy to see alcohol use disorder on the patient's H&P and think that that's the reason for your patient's symptoms. However, Use your critical thinking and deductive reasoning to rule out other causes for symptoms before just slapping on the alcohol withdrawal as your diagnosis. If your patient is acting delirious on hospital day 10, it's not from alcohol withdrawal. It's something else. I once responded to a rapid response call, and the patient was clearly in septic shock. They're hypertensive, mottled, very confused. The nurse had informed the doctor the patient was getting agitated and confused, and the doctor prescribed a CEWA protocol. But the patient had been at the hospital for 10 days. If he was going to have confusion as a symptom of his alcohol withdrawal, that would have happened days ago. This was metabolic encephalopathy from sepsis. So I think that about covers it. Let's summarize all of our key takeaways. It is important for nurses to understand the pathophysiology of why patients act the way they do when withdrawing from alcohol. It helps us explain it to the patient or the family, and I think it helps us be compassionate when the patient's behaviors are challenging and often frustrating to deal with. Chronic alcohol use alters the balance between the inhibitory GABA and the excitatory glutamate neurotransmitter system, leading to withdrawal symptoms when alcohol is abruptly removed. The typical timeline for withdrawal symptoms to emerge is anywhere from 1 to 4 or 5 days since the last alcoholic beverage was consumed. We want to be proactive and diligent to manage and prevent symptoms of withdrawal. This can be achieved by using a CEWA scoring system for managing patient symptoms and deciding on treatment options. Also, benzodiazepines remain a common choice for treatment, but there is emerging use of phenobarbital, which is noted for its efficacy and long half-life, making it a very viable alternative to benzos. As nurses, we play a valuable role in thoroughly assessing patients' histories, recognizing that not all symptoms can be attributed solely to alcohol withdrawal. So feel empowered as a nurse to use your voice to advocate for further investigation or alternative interventions for the symptoms your patient is exhibiting. If you feel like your patient is requiring more, speak up. And finally, let us not forget what our patient might have gone through prior to landing in our care and going through alcohol withdrawal. We all know and love someone who is a recovering alcoholic. As a nurse, you get the opportunity to play an important role in someone else's story of recovery. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.